I'd like to, if I could, begin with a question to Sébastien and Alan, which speaks to this interaction between HIV and TB in parts of Africa, in particular in Durban and in Cape Town. So first of all, how does this problem become tractable? And secondly, in cases, one might expect, based on your predictions, Sébastien, that TB transmission in these endemic areas, HIV endemic areas, would be less. Is that true? And then if it is, how do we address that? And if it's not, what are we going to do with that, Alan?
So there is actually, in addition to these, weird hypotheses, I mean, there is actually some epidemiological evidence that TB, HIV co-infected individuals are indeed transmitting less. And there's actually a quite straightforward reason for this. It's just because these people die very quickly, right? As opposed to TB patients without HIV. As we heard yesterday, there's estimates that in China, for instance, people with TB could be running around for years, perhaps, infecting other people. And because TB is this chronic disease which people get better, they get worse, during this time they will be infecting many, many people. And this clearly does not happen with HIV. In addition to the specific forms of TB, which is really different. So HIV TB is really a different disease than regular TB. Now, even though in these areas much of TB is actually driven by HIV, there's still a lot of people who are HIV negative, and these are actually driving the epidemic. So HIV negatives presumably are the ones which infect the people, and the people who actually die are the ones with have TB and HIV. That's a bit how I see it. I don't know if you agree.
Yeah, I'll just touch on one or two other areas. Firstly, I do agree with you about transmission. Secondly, HIV is not very infectious, which is interesting. This was done early on with needle sticks. Many of the people that were infected with HIV were also infected with hepatitis. And hepatitis in a needle stick seemed always to come across, where HIV very rarely did. So I think you do need a significant dose of HIV. And the reason I mention this is that in the Somkela area that we work now, we have such good epidemiology and public health information that we find people that go HIV positive very, very quickly, way, way more quickly than the disease essentially is established. And so we can put them on antiretrovirals immediately, and that essentially prevents them from going forward. And I was having a conversation with somebody just a moment ago where this issue of, and he just traveled to South Africa, and there is almost a laissez-faire attitude, which is a very, very bad one, where people who are HIV positive but on the drugs essentially feel very good and are not maybe being as careful as they might be. When you're sick as hell from HIV, you don't feel that much like sex, I'm told. And, when you're on the drugs, you could still be infectious and, you living a relatively negative, a simple life there. I mean, you normal life. And so that's, I think, an issue. So I agree. I think, HIV also you can prevent through barrier methods and so forth. And any store you walk into in South Africa has got a huge cauldron of condoms right at the front door. And, people are expected to take some and use them. Unfortunately, not all men take them. Female condoms are used as well, but they're not that popular, and so forth. So there's a lot of educational aspects as well. But HIV you can prevent through changes in lifestyle. TB is far more difficult because you pick it up through breathing. And I agree, therefore, that TB drives it, not HIV.
Hi, Nitin Baliga, ISB. Fascinating session, I think. Just like the sessions yesterday, you covered multiple scales, going from laboratory science, looking at single gene effects, to networks, to epidemiology, evolutionary biology, and it seems like the field has really grown in so many dimensions across so many scales. How does, I mean, this is a general question, I think, how does one really get effectively trained to become part of this new endeavor in global health? I think it really requires cross-disciplinary training. So I was just wondering if you have any thoughts on that.
I mean, my perspective, I mean, we just heard a very nice example of partnerships being built up in South Africa. I mean, I work at the Swiss Tropical Public Health Institute, where very similar partnerships with other places in the world, like Tanzania or Ghana, for instance. And I think that's really the key, to have people, you know, working together and then also being trained. I mean, one thing is looking at all these single genes and high-tech stuff, but I think if you can also be exposed to the real world and vice versa, I think that's the idea, right? So if you have these kind of fascinating institutes available in these different parts of the world, and then exchanging people, training people there, training people here, I think that's really the way forward.
So go ahead now.
Well, I agree. I think collaboration is really the key. And, you know, there are, of course, many different aspects to combating these diseases. One is understanding the basic mechanisms behind disease, part of what we do, and then, of course, establishing collaborations to translate what is learned of the biology and the experiments into something that's tractable and can be deployed in a population. And so I personally feel that it's no longer, and perhaps that's why we're having this symposium, it's no longer even the problem of an immunologist or a doctor or something like that, right? It's really bringing together many different fields to start understanding why disease happens, and then establishing collaborations with hospitals to try to understand how we can perturb those mechanisms, in a sense. Training people is, I will defer to Alan's expertise on that with regard to actually training people, given that he has much more experience in that. But I think one is to train sound scientists. The second is to train sound doctors. And of course, computational biologists who can start bringing these two fields together.
You know, one thing that we found early on at the ISB, we had gone into essentially trying to develop systems biologists by putting people together. So a computational person would work together with a biologist, etc. And it did work to an extent. What was very clear, though, was that if somebody had both those expertises, one person, then things moved much more quickly. In other words, it seemed almost as if all the information had to be in one head, as opposed to lots of heads kind of talking to each other. And I always thought from that the second generation of systems biologists would be far, far better than the first generation, because they would have been exposed to all these things. And you know, so I do believe that there's got to be cross-training as well, not just putting people with different levels of expertise together. One thing that was rather interesting to me, which was something of a big surprise, again here at the ISB in early days, I had thought that biologists would have a much harder time with computation than computational people would have with biology, because we'd all been little and thrown rocks in pools and caught frogs and all this sort of stuff, had some sort of link to biology. It turned out to be the opposite, and the reason for that was evolution. I found that computational people at that time, at least, had a very difficult time dealing with evolution, which is sort of, you know, there's no logic in it, really. Whatever works, you pick up. And if the systems had been intelligently designed, a clever computational person or engineer could reverse engineer it. But evolution is much, much more difficult to reverse engineer. And so that was a bit of a surprise to me. And that, again, is a reason why I thought people who did computation should also do biology and the other way around. And Steve Ramsey and Alan Dirks, who were two computational people in my lab, they both did a year at the bench while in the lab getting trained in the biology as well. And both of them have turned out to be absolutely superb systems biologists.
I thought you were going to say that computational biologists were less well evolved. So I have another question, maybe, and each of you in turn can sort of throw your answers at it. So yesterday we heard Trevor Mundell talk about systems biology, but he spoke of it in very, epidemiological terms. And today we've heard far more about the molecular underpinnings, at least at the genome level in TB. We've heard about one or two particular molecular networks within innate immune responding cells. And then we've heard a lot about the molecular networks primarily in peripheral PBMCs in blood. But this is, and then yesterday we heard Gary Nolan talk about this immense population of, and Jim Heath to some extent, this immense population of immune cells. And so if the goal with systems biology is to be able to link all of that information and to be able to derive new vaccines, drugs, diagnostics, or treat cancer through immunotherapies or identify new strategies for TB, how do we begin to link all of this and make some sense out of it, especially for the uninitiated, rather than what appears to some of us probably like more of a scatterbomb approach? I'll give that to you, Naeha.
Thank you. That's a very easy question. Well, I don't know how to answer that, honestly. I really think that, that is the biggest problem, to try to understand what happens in different cells when we go after a particular target, which cell type to go after rather than indiscriminately target the whole immune system, essentially, right? And that's part of the problem with current chemotherapies, if you will. And so, the approach that we're trying to take to that is to really leverage our system to understand signaling pathways triggered by innate genes in different cell types. They might not, their functions could be different depending upon the cell type, of course, so one has to be mindful of that as well. I really think that as far as I see it, it is early days, even though we have come pretty far with regard to, trying to model some of these immune cell interactions. I think we've been reasonably successful in modeling molecular networks, as in what's happening within cells, but really going a step ahead of that to see how cell-cell interactions, how they're positioning within organs, how they're trafficking between different organs actually influences development of disease or of immune responses. That's really an unmet challenge. And I agree with what was said previously. It'd be great to have people who are trained in both computation as well as experimentation. But I do think that this requires a scale of modeling that is much beyond what we're doing right now. Ilya has talked at various times about this platform called Biocellian to start modeling some of these cellular interactions. And I think that's the kind of stuff we need to really start leveraging biological information that we generate to start modeling cellular interactions.
Maybe I just add a few words. I mean, we talked a lot about dogmas, and I think even though this so-called systems biology obviously is very, very interesting and driving very quickly new knowledge, I think it's important also to avoid creating new dogmas. I'm not saying anybody is doing that, but And I think perhaps one way to do that is to, from the beginning, bring in the real world. So keep, the message about bringing in real pathogens and real humans and real patients and real environments, etc., to make it as relevant as possible, to avoid, creating these dogmas that we heard about. And then there's systems biology, there's systems of diseases, but there's also systems of health, and then there's systems of public health, right? So that's a bit what I think you mentioned. So once you understand the biology, I think you need to understand how does that biology interact with the sociology. I think that's also important to keep in mind, particularly assuming we had a new vaccine. I mean, how are you going to deploy that, or even diagnostic? I mean, I was very dramatic when I was saying, new diagnostics don't really exist in TB, which is not entirely true. There's actually some progress there, fortunately. Molecular diagnostics, which accelerate quite dramatically the diagnosis of tuberculosis. The problem, and they have been actually massively rolled out in places like South Africa, but people realized that they had zero impact on the outcome of the patients. And that's clearly something to do with the health system. So how are these new tools deployed? So it's not sufficient to understand the biology, the mechanism. We actually need to understand how we actually implement some of these new tools in the real world.
I think that the real challenge here is integrating different scales of information. And I think lots of really smart people are working on that, and I have high hopes as to whether we'll be able to do that or not. One thing that is clear to me is that the entire team has to be involved in setting up a clinical trial, because we found with the malaria trial, which I didn't talk about, we found that when just the physicians and the sort of epidemiological experts, the clinicians, set up that trial, we had to shoehorn the information after the fact into the various tools that we had. And then turning the thing around, when everybody was sitting in the room, you could say, look, I need that level of granularity to the data. And so we need to take samples at far more times, or this time or that time. And that essentially resulted in, I think, enormous insight into the outcome. So for certain, protocols for clinical trials have to include everybody who's going to not only run the trials, roll it out, etc., but also analyze the data after the fact.
Hi, can you hear me okay? So I'm Deidre Dillon. I work for Providence in clinical research, mostly outpatient oncology, but I have an ag science background, so this has been phenomenal. I really appreciate all of the fabulous intellect in the room. My question is to this panel, as something that wasn't talked about as much as that time points at perinatal transmission of HIV, and maybe is that a window of opportunity in clinical trials? As we know, mothers are very receptive when they are about to give birth, and looking at the public health outreach of this and the timing and the sampling and all of that. I don't know in South Africa what the state of prenatal care is. Could you touch on that just a little bit?
South Africa has got a very strong infrastructure and also very good clinicians, and what the antenatal clinics are really well developed, and a lot of community work goes on and education goes on in them. And as you point out, the mothers are usually very interested, or in actually giving birth to healthy babies. So they are very receptive to the information, far more so than any other population. So there's a lot of work in those antenatal clinics. Yeah, there was one other point I wanted to make. I'll think about it and come back to you. Not getting any younger.
So if I could just ask one final question. So most of what we've heard about over the course of the symposium is really about first world medicine or developed world medicine. And here we are talking about global health, primarily in the developing world, with the exception of Naeha, who spoke much more broadly about immunology. But I wonder if Sébastien and Alan can just tell us why we should care about, beyond the humanitarian issue, but from a scientific perspective, how does what's happening in the developing world, when we're thinking about TB and malaria and HIV, impact health at Providence or in the developed world?
So perhaps one thing which comes to mind is how to run clinical trials and developing tools more cheaply. I mean, it's generally stated that big pharma, needs like between 1 and 3 billion to develop a new drug, a new vaccine, etc. And obviously, when you work in diseases of the poor, which is essentially what we're doing, be it TB or trypanosomiasis, sleeping sickness, etc., you obviously don't have that money. And yet, people are able to try to come up with new ways of developing these tools in a much more rational way and keep saving money. And perhaps that's one of the things we could learn from working in partnerships with countries, which are poorer, which would perhaps even help us, designing new cancer treatments much more cheaply than is currently possible.
I think that it's quite difficult for people in the developed world to appreciate what it's like to live in these resource-poor countries. And, you could go down the entire scale of sort of sociology that exists there. So that's very difficult. And I have many a time gone to Congress to try to interest them in funding some of these resource-poor country diseases. And it's always been difficult because they've had to balance the needs of the US with the needs of others and so forth. But what was interesting is I came back after we found totally drug-resistant TB, and I remember going to Congress again and basically said, you get on an airplane, a guy in Dakar who's got drug-resistant TB gets on the plane as well. They're recycling the air all the way through to JFK. When they land in JFK, these people all take planes to everywhere. What do you think of that? And, we got quite a bit of money. So I think most people are quite self-interested in disease, but when I think sadly, when I think people see that this actually can touch you as well, their interest is piqued. There's that. The other thing I think is that differential pricing for the drugs really has to happen. I remember when the first antiretrovirals came out, in South Africa, they cost $12,000 per person per year. Now, at $12,000 per person per year, those drugs may as well not have existed. One couldn't roll out the drugs. And I hate to admit this in front of my colleagues in the pharmaceutical industry, I was part of the group that broke the patent, and we synthesized the drugs in Brazil and in India at Cipla. And I could see when we were negotiating with the CEOs of these drug companies, they're good people. They really wanted to pass the drugs on, but they had to answer to their shareholders, etc., who would see them making decisions sort of based on social sensitivities rather than on a financial basis. So it wasn't, I'm not blaming anybody for doing this, but we just decided to do it. And that made we went down to $300 per person per year, so we could start rolling out. And the Clinton Foundation at the time, Bill Clinton just came away from being president, he got involved in the negotiation. We got it down to $210 per person per year. And so we could roll out the drugs. It's extremely difficult. I mean, there you're breaking international patent law. It's not a good thing to do. It was an extremely difficult set of negotiations and decisions that had to be made. So I hope that some differential pricing can happen within the industry, and that shareholders can be convinced that this is a reasonable way to go, and that sort of socially responsible economies can develop within the developed world, so that some of these resources can be used in the resource poor countries. Maybe a pipe dream.